Respected General Jaswal sir, Chairman of CCR, Dr. Sri Sadeva sir, Dr. Kapoor sir, Dr. Andy Swami sir, JSSN sir, and other dignitaries, faculty, and residents. Today we are discussing the topic of organ donation. In the last 10 days, you have heard a lot about organ donation in newspaper and different social media. But I tell you, this CCR has nothing to do with that news or media. We have already planned the CCR out a month back. I'm grateful to the chairman of CCR committee to permit us to present this presentation before us. We at Mahatma Gandhi Hospital started organ transplant program way back in 2012, and since then we have done 2077 transplant. This number maybe a little more now because my data is up to 31st March, and because we are the major stakeholder of organ transplant program in Rajasthan, it becomes very important for us to understand all the nitty-gritties of this program and understand the law so that we do not commit any mistake. I will deliberate this program in 4 sections. First will be how to prepare our hospital for this program. Secondly, how we certify the brain stem death. Thirdly, how we maintain our potential organ donor after the brain death stem declaration. And lastly, after the retrieval of the organs, what we do, how we dispose of the body, and we take the 4 phases. Now, what is organ donation? When a person allows an organ or tissue to be removed for transplantation for therapeutic purpose, legally, either by consent while alive or after death with the consent of next of kin. In this definition, you will find 3 words are very important: therapeutic purpose, legally, and with consent. The whole program revolves on these 3 words. So you always have to keep in mind these lawful activity and consent. Who can donate? As far as disease organ donation is concerned, anyone can donate. There is no restriction of any religion, caste, or ethnicity. But no live organ donation below 18 years of the age is possible. No, there will be no live organ donation or tissue donation below 18 age of the 18. And for the live organ donation, there is no upper limit. Who cannot donate? People with HIV, syphilis, hepatitis B, C, and tuberculosis, active syphilis, they cannot donate. Simply malignancy, the exception to malignancy is intracranial primary malignancy and localized skin malignancy, skin cancer localized. These are the exceptions they can donate. Systemic or local infection, bleeding disorder, slow virus, and so on. You can even the poisons. Now, who cannot donate? It continues. The social conditions may the person who is having drug abuse in the injectable form, he cannot donate, and untreatable mental disorders cannot donate. Treatable can. Tattooing and piercing. A word about it. With the history of the tattooing and piercing in last 6 months, cannot donate the organs. Otherwise, they can. And there are some organ-specific criteria which the operating team will decide which organ is suitable for organ transplant or not. These are the 6 organs which can be donated, and by these 6 organs we can save 8 lives and sometimes 9 lives. Tissue donation. These are the tissues. And other than these 6, there can be bone and tendons are there. So the difference between the tissue donation and the organ donation is that for tissue donation, you do not need an intact circulation. Organ can be retrieved after 6 hours of the death without any refrigeration, and up to 12 hours of the death with refrigeration. So this is the difference. And now, after retrieval, how long organ can survive? That is the cold ischemia time. For heart, it is 4 to 6 hours. Lung, same. Liver, 12 to 18 hours. Pancreas, 12 to 18 hours. Kidney, 36 hours. and intestine 12 to 18 hours. Now, the most sought organ in demand is kidney, followed by liver and then by heart. And now, what are the types of organ donation? There can be two types, basically, living or donor transplant or deceased organ transplant. In the living organ transplant, it can be near relative. Near relative means genetically related person. That means mother, father, brother, sister, grandchildren, grandparents. And then other than near relatives means chacha, mama, hua, phupi, mosi, mosa, etc. So, and then comes deceased organ transplant. In this, as per the law now, the brain stem death has been taken as death, and when the person is brain stem death, he is his circulatory system is intact, his digestive system is intact, his respiration is not there, he's in coma. Relatives next of kin we can take the organs. Second is donor after cardiac death. This has to be done within few minutes of the clinical death, cardiac death, and it is practically not being done in India. Only PGI Chandigarh has started this program, and they have done a few cases. Now, why this problem? Why are we dealing with this problem? Because there is huge demand and supply. You can see from this chart, this slide, that we are hardly able to cater for the 10% of our demands, and the waiting list, registered waiting list, is about 1,12,000, and one name is added every 10 minutes in the waiting list, and 20 people die every day from the waiting list. And if you see, 1 lakhs road traffic accidents occur in India every year. Out of that, 35% are head injuries, which can easily donate the organs, but it is not so. Brain death organ donation in year 2022 was only 941, and if we talk about the rate, organ donation rate is 0.6 per million of the population. We talk of the लाखों में एक, यहाँ हम लोग 10 लाख में भी एक नहीं बन पा रहे. So now coming to organ donation in India, in year 2022, we have all total organ donation is 16,941. Now you look at the chart, most of the organs are from the live donations, and very few, about less than 3,000, are from deceased organ donations. So the live donation has got inherent problems to the donor itself, and it has got chances of organ trading and corruption. So we have to encourage deceased organ donation. Now, why it is? What are the challenges before us? Because we have got high burden of organ failure patients in the community, and it is on the rise every day because the prevalence of the hypertension and diabetes. Then there is a huge demand of supply, gap between demand and supply, lack of the awareness about the brain stem death concept. A survey was done in a hospital where only 47% of the nursing staff have ever heard of the concept of the brain stem death. And the number of we are doing very less number of the brain death certifications. Reasons will come later. And there is non-availability, the infrastructure is not available, particularly in the government sector. Then there is a lack of awareness and attitude about the organ donation. A lot of myths and a lot of beliefs. People do not come forward for organ donation. And even after donation, there are problem of the transportation of the donated organ to different places. And cost of the procedure, unless it is covered by some insurance or government scheme, some people cannot afford it. So they refrain from it. And then there is lack of organized networking system. In spite of all these odds, we have got some achievements also. Now we are third country in the world in the number of the transplants after USA and China. And in the year 2013, we could hardly do 5,000
transplants. Now we have done more than 16,941. This figure now in 2023 has crossed 19,000. Now we have developed capacity for the rare organ transplants like pancreas, intestine, etc. And the decrease of disease organ population has increased from 0.27 in 2013 to now 0.26 million in 2023. Disease organ now in 2003, for the first time they have crossed mark of 1,000. Today, I think today's data is till 31st December it was 1,028 and 31st March it was 1,062. So now these things are improving. 529 hospitals are doing transplants.
In India?
Yeah?
529 in India?
In India. So these are the age-specific, organ-specific age criteria. However, they are not very stringent criteria. This depends on the physiological status of the organ and of the donor. As Dr. Naimish Mehta was mentioning me, he has transplanted liver of a person of 84-year-old. Am I right? Yeah. So now what used to happen before 1991, there were unethical practice in the organ transplant program. There were organ trading, there were trafficking of human organs, and there was allocation of the organs to recipient was not proper. Rich people used to get organs, poor people never used to get it. And there was transplant tourism. People used to move one country to other to get the organ transplant done. Now, because of these problems, in 1991, the WHO laid down certain principles, guidelines, that was preference to diseased organ donation rather than live organ donation, and preference to genetically related organ donors. Informed consent has to be taken from the competent person, and there should be no undue pressure or influence. There was no commercialization, and there should be fair distribution of the organs. Based on these principles, in 1994, the Transplantation Human Organ Act was enacted, and it had certain features. It came to force in 1996, but these laws in this act was very stringent, and the family only father, mother, sister, brother was included. Then later on it was realized that donor pool is not sufficient to cater for our requirements. So in 2011, process started from 2008, and then up to 2011, there were amendment in this act, and then in 14 act was applied, and 2015 we started National Organ and Tissue Transplant Registry. Now, aim of this act was to registration for removal, storage, and transportation of human organs for therapeutic purpose only, and prevention of commercial dealing. Again, I remind you, the organ can be retrieved only for therapeutic purpose, not for any research, not for any scientific purpose. And to establish legal framework of the brainstem death and methods for legal utilization of the organs for transplantation. Now, the amendment which was made, it included, in the near relatives, included grandparents and grandchildren also. Then swap transplant for the first time was included in amendments. Tissue donation and tissue banking was included. Then there is a mandatory registration of hospitals which are doing transplantation. Previously it was not done. Now the hospital which is doing transplant has to register themselves with the appropriate authority. Then there was a non-organ transplant retrieval centers were started. These are the hospitals which have a low capacity for organ transplant, but they have proper ICU and operation theatre and trained manpower, so they can retrieve the organ and transfer to the transplant center. And then appointment of transplant coordinators was made mandatory for organ transplant hospitals. And now, whenever we suspect a person to be brain dead or brainstem dead, it is mandatory for us to request his next of kin for donation. Previously it was not so, now it is mandatory on our part. Similarly, brainstem certification. Previously, the presence of neurologist and neurosurgeon was must in the brainstem certification. Now, any intensivist or anesthetist also can replace the neurologist and neurosurgeon. Now, national networking has started. National registry has started. In the eye donation or cornea donation, previously only ophthalmologist was supposed to retrieve the eye or cornea. Now, a trained technician can do so. Now, for the prevention, higher penalties have been laid down for the violation of these acts. The penalty of up to imprisonment of 10 years and financial penalty of 1 crore can be imposed on violation of these rules. And we have to have greater cautions in case of minors, mentally challenged persons, and foreign nationals. Now, no organ can be removed from anybody without authorization. Authorization has to be from out of one of these 4 committees. From the near relatives, those who are genetically related, competent authority can do authorization. For others, the state authorization committee or hospital-based authorization committee has to give authorization sanction. Now, how do we register a hospital for transplant? So we have to apply. There is a form. Form 12 is for the transplant center, 13 is for the retrieval center, and 14 is for the tissue banking. These forms I mentioned, and then there is an appropriate authority. We have to apply to appropriate authority. In our case, Secretary Medical Education is appropriate authority. Then there is an inspection by a board of experts, detailed by the appropriate authority. After inspection, the experts give their recommendation to the government, and they grant us permission for 5 years in the form 16. When any hospital which is transplant center is automatically retrieval center also. We need not to take separate permission for retrieval center. And the registration is renewed every 5 years on form 17. Now, why I am talking these forms? Whatever we do for this program, there are specific prescribed forms available in the rule, in the act. Only that form, the prescribed language is there. We cannot deviate a word from that forms, whether we are apply or we take authority or whatever we do. The set forms are there. I will mention later on. Now, in our case, the hospital-based community, any hospital which is doing more than 25 transplant in a year can have its own authorization committee, and if we have that, we can have authorization for other than near relatives also, like Mama, Pupa, Hosi, Adi. Now, in our hospital, we are having competent authority in the form of Principal Dean and Controller Dr. N.D. Soni. To help him, we have got a scrutiny committee comprising of these 7 peoples, and I am the member secretary of that committee. Minimum quorum for this is 4, and no member of this team should be a member of the transplant team. Now, after this, we have to have a brain stem death committee. It has got 4 members. The medical student is permanent member for any brain death declaration, and the second member has to be teaching doctor of the patient. Third member has to be a neurophysician or neurosurgeon or anesthetist or internist. Or there has to be, fourth person has to be an independent physician from the panel approved by appropriate authority. We cannot take anybody like this. We have to get the panel approved from the authority. And this is our panel of approved by the we have got 21 people in this panel. Whenever we convene a brain stem death committee, we take people from this only. Now, there are certain regulatory bodies to regulate all this program. There is a NOTP, that is National Organ Transplant Program. It is headed by the Director General Health Services of India in the Ministry of Health and Family Welfare, office in the Nirman Bhavan, New Delhi. Then there is a NOTO, that National Organ and Tissue Transplant Organization. Its office is in Safdarjung Hospital, Delhi. Then there are 5 ROTO, Regional Organ and Tissue Transplant Organization. They are located in Chennai, Mumbai, Calcutta, Chandigarh, and Guwahati. And ROTO is also functions as ROTO also. So there are total 6 ROTOs, and there are 60 ROTOs. ROTO means the state organ and tissue transplant organization. The ROTO are located in medical colleges, government medical college of state capitals. So there are 16 states are participating and 6 rotos, 22. The other states are not participating, particularly Telangana, Andhra Pradesh, Karnataka, and the Northeast Seven Sisters, except Manipur. Manipur has started this program. Now this is a pictorial diagram of the same. There is a director general with him, under him is roto, then 6 sotos, and then 6 rotos and 16 sotos. And every soto has got a transplant hospital or a retrieval center or tissue bank center. The tissue bank center is also known as biomaterial bank, biomaterial center. So often people may ask you how long a person survives after organ transplant. So in case of the heart and liver, it is 80%. For kidney, it is 88%, and for lungs, it is about 55%. Now, whenever we come across a possible or potential brain stem death person, what action we should take? We should recognize potential brain stem death as early as possible in the emergency or in the ICU. And the optimization of donors should be started then and there only, without so that organs are maintained in good function and body is maintained. Alert is sent to transplant coordinator. Then we request the intensivist for the assessment to rule out any other conditions of the coma. Then we convene a brain death stem committee. It is done by me, like MS. And then the optimization of the condition of the patient is started simultaneously, and then apnea test is performed. Now, for the further deliberations on apnea test, I will invite Dr. Ashish Jain. Please, Ashish Jain, please.
Thank you very much, sir. A very good morning, all the respected dignitaries, senior faculty members, colleagues, and dear students. So, death. Historically, it is identified as cessation of cardiac respiratory activity, or decapitation, or putrefaction, or sometimes absence of any motor activity or to a painful stimuli or noxious stimuli. But in the era of widespread use of mechanical ventilators and life-sustaining therapies, there is a need arises to identify physiological parameters for death. It is identified that when the brainstem is irreversibly damaged, then connection between the cerebral cortex and the body is broken. It is like a car without an engine or a brake. It is considered as brain death. And please remember, brain death is death, legally also. And it happens when there is decreased blood supply or hypoxemia or damage to the endothelium or acidosis to the brain tissue, which will lead to edema of the brain or the neurons, leading to brain herniation. When you can suspect a patient might be a brain stem dysfunction. A comatose patient who is on ventilator, who is requiring decreased doses of sedatives or muscle relaxant, whose cuff reflex is now disappeared, who is producing excessive amount of diluted urine like water, and who is having pyklothymia. If it is there, then you can suspect this patient might have brain stem dysfunction. Where? In intensive care units or in emergency department. And who can suspect? Any medical professional or nurse or physiotherapist, or sometimes patient attendant can tell you, sir, ये patient हमारा अब कोई respond नहीं कर रहा है. Please suspect. So it is a request. Immediately inform to transplant coordinators or medical superintendent or intensivist, and don't send patient lama. Please. Once you have identified, as Dr. Ashish Gupta sir has just enumerated, 4 members from the brainstem declaration committee will examine this patient. And the first thing, they identify the cause of coma. This is the most important thing. You have to be confirmed that this is the problem which causes coma in this patient. a coma which is lasting for 6 hours, or in case of cardiac arrest and when the patient has achieved ROX, 24 hours, when there is no respiratory activity, when all the brainstem reflexes are absent, then these are the possible causes which can lead to these problems. Either it could be hemorrhages, subarachnoid hemorrhage, intracerebral hemorrhage, or subdural hemorrhage, extradural hemorrhage, infarcts, malignancies, some poisons, or even hypoxic brain injuries. Once you have identified the cause of coma, then you should exclude the confounders, which is coma mimics. What are those? Locked-in state, akinetic mutism, brainstem encephalitis, Guillain-Barré syndromes, sometimes snake bites. We have 2 patients which we thought that it might be patient is brain dead, but they recover after some time. Some drugs, depressant drugs, primary hypothermia, moderate to severe category when the temperature is less than 35 degrees centigrade, severe metabolic endocrine disorders, severe shock, and when respiratory arrest is there requiring muscle relaxation, you should not perform this brainstem cell deterioration. Once you have removed these all confounders, then we'll go for the determination of brain death. And how? With the presence of irreversible coma, absence of cortical reflexes, absence of brainstem reflexes, and presence of apnea. And we repeat this test 2 times with a difference depending upon patient condition and patient age. But minimum time interval would be 6 hours. So there is absence of cortical functions. That means there is no spontaneous movement, eye opening, or response to any auditory, verbal, or visual commands. Absent motor response to pain. But as spinal tract is intact, so patient might have some jerky movement, triple flexion response, Divyansh response. These are called Lazarus reflexes. Then there will be absence of brainstem functions also. There will be no light reflex. People will be fixed, mid-dilated, or unequal in size, maybe fully dilated. Loss of corneal reflex, gag reflex, cuff reflex, oculocephalic, oculovestibular, like Doll's eye or cold caloric test, and there is no spontaneous respiratory efforts. Once we have done this, then we need to go for the apnea testing. There are certain prerequisites which should be fulfilled. Patient should be normotensive. That means patient's systolic blood pressure should be more than 90 mm of Hg, either with the help of fluids or vasopressors. Temperature should be more than 36 to 36.5 degrees centigrade. Patient should be in euvolumia. That means for last 6 hours there is positive fluid balance, and there is absence of hypoxemia. Once you have achieved this, then go for the preparations. Change the ventilatory settings to achieve the desired PCO2 level, which is between 35 to 40. Desired pH level between 7.35 to 7.45. Give pre-oxygenation 100% oxygen for at least 10 minutes prior to you conduct the apnea testing, and get a ABG, get a arterial line and a ABG. This ABG we label as a baseline ABG. From here we start our testing. We expose the patient from the chest and the abdomen to look for any movement. We disconnect from the ventilator. We introduce a nasal cannula through the tube in the trachea and place it 2 cm above the carina, and we give 100% oxygen at the rate of 6 liters per minute. We wait for 8 minutes. At 8 minutes, we get the second ABG. What we will see? We will see the rise of PCO2 level. If PCO2 level is now 60, or there is more than 20% rise in the level of carbon dioxide, then the test is labeled as positive. If you are not able to achieve these parameters, then you wait for 2 more minutes and take the third ABG at 10 minutes. If that ABG is having these parameters, that means PCO2 more than 60 or rise in more than 20, then the test is positive. In some cases, patient might develop hypotension, arrhythmias, and hypoxemia. So what will you do? We take an ABG at that time and we connect the patient to the ventilator. That means we abandon the further testing. We see that particular ABG, and if it is showing PCO2 rise more than 60, we take it as a positive test. If in any circumstances PCO2 level doesn't rise more than 60 or more than 20 from the baseline, it is called indeterminate testing. We repeat the test after managing all the confounders, or we'll repeat it after a few hours. There are certain barriers. We have discussed the hemodynamic instability. If there is pulmonary dysfunction, rise of PCO2 or low PaO2, we can manage with the ventilatory, either by giving PEEP or by recruitment maneuvers. There are certain other factors. If suppose patient is having cervical spine instability, you cannot do a oculocephalic reflex. If patient is having poisoning or some heavy drug overdose, then you should wait till the blood level of that particular drug is in the normal range. Or if patient is having, suppose, ototoxic drug, you cannot go for the oculovestibular reflexes. So these things should be kept in mind. There are certain ancillary testing should also be there. When you are not able to find out apnea test is positive, that means it is indeterminate due to some reasons, then we can go with these tests like conventional angiography, whether it is CT guided or MR guided, in which we see that there is no intracranial filling at the level of carotid bifurcation and circulophilus. Or electroencephalography or EEG, when it is showing no activity for at least 30 minutes. Transciliar Doppler, which is very easy to perform in ICU, it can also be done, which shows absence of diastolic peaks or reverberations are there. PET-CT with technetium-99 scan shows no uptake in the brain, or we label it as a hollow skull syndrome. And SSP or somatosensory evoked potential N20 at the median nerve, which should be absent. This is the picture of Form 10, which Sir was also discussing. It is provided by the government, and we fill each and every point in the form. It is signed by 4 members of the Brain Stem Declaration Committee members. One of them will be the medical superintendent. Once you have identified and you have certified the patient, then there is counseling. Counseling should be clear, correct, unambiguous information to be given to the patient attendant. We should be very careful when we choose our language and the words. Remember, every member of your team should say the same thing to the patient family. अगर वहाँ कोई discrepancy है, तो समझ लीजिए आपको बहुत trouble होने वाला है. And counseling to be done to the key person among the next to kin of the deceased. Who can counsel? Primarily, it is the job of the primary physician who should counsel, along with the nursing in charge and the intensivist. But any member from the transplant team should not be part of this counseling. बैठना ही नहीं है, दिखना भी नहीं है आसपास. When you give in the information, then according to the spikes protocol, patient family or next to kin will go into the various stages of grief. First of all, they will be in denial, then anger, then depression, then comes this acceptance. And when you feel that now family members are in the acceptance stage, you can start talking about organ donation. How you start? First ask them, क्या आप अपने मरीज की कॉर्निया या आंखें डोनेट करना चाहते हैं? अगर उनमें थोड़ा भी डोनेशन के लिए परसेप्शन होगा तो वो कॉर्निया को डोनेट करने के लिए एग्री करेंगे. जब कॉर्निया डोनेट करेंगे, देन यू गो फॉरवर्ड, आस्क अबाउट द ऑर्गन डोनेशन. कॉर्निया के लिए मना कर दिया तो ऑर्गन डोनेशन पे जाना ही नहीं है, छोड़ दीजिए. यू फिल द फॉर्म, you take the consent if they agree for the organ donation, and remember, consent can be withdrawn at any point of time and it is organ specific. Now before asking, once organ is there, then we'll go for the organ optimization, donor optimization. And before I ask Dr. Divyansh, there are certain queries I would like to clarify here. One is, who can perform apnea testing? I have cleared that 4 members from the team. How much time does it require to perform apnea test? If a patient is already optimized, hardly 15 to 20 minutes in each testing. What is the cost of apnea testing? It is free of cost. Do you need consent for apnea testing from the family? There is no need to take consent, but you should inform that these are the things which we are going to do. What will be the time of death mentioned on the death certificate? क्या लिखेंगे time? Second apnea में ABG जिसमें desired level of PCO2 हमें मिला है, that will be the time of death. That should be mentioned on the certificate. Can I remove ventilator after apnea testing? Yes, you can remove ventilator after apnea testing. Who will bear the cost of treatment after brain death certification? It is the institute who will bear the cost of therapy. You cannot charge family once you have identified and certified patient as a brain death. Is it possible to donate organ to my patient? कई बार पूछते हैं साहब मैं डोनेट तो करूंगा लेकिन मेरे फूफा जी हैं उनको जरूरत है उनको दे दो। आप ऐसा नहीं कर सकते। इवन किसी को नहीं पता होता ऑर्गन किसको मिलने वाला है, वो लिस्ट के हिसाब से ऑलरेडी प्रीडिफाइंड होता है। थैंक यू वेरी मच।
Thank you, Ashish sir. Good morning, respected dignitaries. So now we have certified the patient. Now the patient is brain dead. How we are going to proceed for the management of this potential organ donors? So the reference for my further presentation will be this article. This article is published in Indian Journal of Critical Care Medicine in the year 2019. So they took the Indian perspective. So as an intensive, what is our role? So our role is to maintain these patients are mostly hemodynamically unstable patients. So our role is to maintain the hemodynamic stability of these patients, diagnosing the brainstem death, as Ashish already told. Now the preparing the family for the devastating news, how we are going to counsel the family, and if the patient is not going ahead for the organ donation, how we are going to counsel them for the end of life care. As an intensivist, our role is to implement such policies and protocols for successful running of this organ donation program. And along with that, we need a strong coordination with the transplant coordinator, along with the organ procurement team, along with the family members. So, what is the pathophysiology behind brainstem death? Basically, whenever the cerebral injury takes place, there is a rise in the intracranial pressure, which will lead to the herniation. What it will lead? Ultimately, it will lead to hemodynamic instability, as you can see. Along with the cerebral ischemia will cut down the blood supply to the HPA axis, which will ultimately lead to the endocrine dysfunction, which will lead to multi-organ dysfunction. So these patients are hemodynamically unstable, along with they have a multi-organ dysfunction. Now we want to procure such organs. These organs are already under stress. Now we want to procure these organs. So how we are going to proceed? First of all, these patients are, as I already told, these patients are hemodynamically unstable. We need to expand their volume. The isotonic crystalloids will be the preferred solution for the volume expansion in such patients. Now, to be marked, what should be the vasopressors of choice in such patients? Routinely, the vasopressor of choice in routine care is norepinephrine. But in such cases, we need a vasopressin because these patients, they land up with the diabetes insipidus. They are polyuric. They are extremely dehydrated. They are losing free water through the kidney. So we want to retain that free water through the kidneys. So we need a vasopressin. We may require a hormone replacement therapy if the hemodynamic goals are not met or the ejection fraction remains less than 45%. These patients, they have frequently endocrine dysfunction is there. In such patients, they may land up with diabetes insipidus, thyroid deficiency might be there. They might have a corticosteroid deficiencies. For the successful procurement of the organ, we need to give a methylprednisolone dose, a single dose of 15 mg per kg or 1 grams IV stat. We need to maintain the blood sugar levels. Talking about the other organs, we need to ventilate these patients with the lung protective ventilation strategies. These patients are prone for hypothermia because of the loss of the thermoregulatory system. So active warming may be required in such patients. And for the renal part, if you want to procure the kidney, we need to maintain the renal perfusion pressures in such patients. We need to manage the fluid accordingly in such patients, which may require a liberal fluid management, but it might not be good for the procurement of the lungs. So my question with the audience is. Now talking about the infection parts, these patients are under huge stress. They might be case of a traumatic brain injury, or they might be suffered as a huge stroke. These patients might suffer from a huge stroke, or maybe a case of malignancy. Now these patients are immunocompromised. These patients may land up in sepsis. Now my question is with the audience is, if the patient is with bacteremia or sepsis with a positive blood culture, so is it considered a contraindication for the organ donation? So answer will be no. No, it is not considered for the contraindication to organ donation provided if you are giving a pathogen-specific antibiotic to that patient for at least 48 hours before the procurement of the organ. Even if the patient is having say a pyogenic meningitis or some sort of meningitis, if you are giving the patient appropriately organ-specific antibiotic, antimicrobial, you can ask the patient for, you can go ahead with the organ procurement. So the actual rate of unexpected infection transmission from donor to recipient is very low. What they have seen, it is occurring in less than only 1 to 5% of the patients. So to conclude, what we need a clinical checklist for managing such patients. We need a necessary protocols along with policies to ensure the successful running of such programs, along with periodic training programs for the healthcare personnel who are involved in the organ donation program. So this is the checklist what we are following in the managing such patients in our intensive care unit. Basically, we are going with the system-wise what we want to do in such patients, and these are our targets. So we ask the nursing team to meet these goals before the procurement of the organs. That's all. Thank you.
So what we do after the appeal test and the optimization, we inform the relatives and request them for organ donation, and inform SOTO with all the details of the patient, age, sex, and all the investigation. We inform the SOTO. The SOTO is the person who allots the organs to different hospitals. Then second appeal test is performed, when test is declared. Then we consult the relatives. Then we call the potential recipients who are on the waiting list. All the hospital who have been for whom the organ has been allotted, they will all call the different recipient, and we call 4 to 5 recipient and send for the matching. And then we start the organ preservation and the arrange logistics for the transport of the organ. If we have to provide green corridor, we have to arrange that. And then we, in case of medical legal cases, we have to inform the police. In medical legal cases, no organ can be retrieved without permission of the police. So we have to inform the police. Then we have to inform medical jurist. Only in case of medical legal cases, postmortem is a must. And postmortem in these cases may take place beyond the office hours, in night or day, whatever time, depending on the choice of the next of kin or relatives, what time they want to take the body. And sometimes it is generally done in the operating theatre itself. And postmortem should be done in such a way, the organ retrieval should be done in such a way that cause of death is not jeopardized. And then we have to do retrieval at scheduled times as per the wishes of the relatives. And then we arrange handing over the dead body to the relatives with the due respect. And then finally we inform whatever we have done to our regulatory bodies, that is SOTO, NOTO and ROTO. This is all from my side. Now I request Dr. Naimish N Mehta sir for his comments from the vast experience of organ donation. Dr. Naimish N Mehta sir.
Thank you very much for inviting. And the whole idea why our emeritus chairperson wanted this session is that we educate our own in-house team members about organ donation, what is brainstem death, and my colleagues have taken a pains to go through and have done a wonderful job for that. So just want to again reiterate the statistics, how many transplants are required, how many patients are being added every year. So if you look at the number of transplants, organs wise if required, the kidneys required are more than 200,000, livers, hearts required is 50,000, liver 50,000, but what we get is less than 10%, and the numbers in our own country will now show that in the last year, the number of transplants which have been performed is about 10%. If you look at the requirement of kidney is about 2 lakh, where we have done only 12,000. The number of liver patients waiting is about 40 to 50,000 per year, of which we have done only 4,000. Heart, 50,000 patients need a new heart, of which only 200, and here it's not even 10%. It's about less than 1% where we go and give these organs to these patients. So rather than taking these organs back to heaven or burning them or burying them, it is always better to educate our other colleagues as well as the patients to try and donate these organs. Though India is one of the major countries where we are doing number of transplants are significantly higher, we are the third largest country in the whole world in terms of number of transplants. But if you look at the numbers, most of these numbers are are living donor liver transplant. We are in fact much higher than even United States in terms of doing living donor liver not only liver, living donor transplants. So in US there's only about 6,000 transplants done, whereas we have done about 13,000 living donor transplants done in our country. And if you compare any other country, we are much higher in terms of those numbers. How does these numbers correlate to our own state? So in Rajasthan, the last year's data showed that 737 live kidney donations had happened, whereas only 10 kidneys were procured from cadaver. 45 livers were obtained from a living donor and only 4 from a deceased donor. Similarly, deceased organ donation, 3 heart, 1 lung. So you look at these numbers, which just tells you that 98% of the transplant done in our state was from a living donor and only 2% from the deceased donor. As compared to this, you look at the United States, the deceased organ donation rate is about 85% and only 15% of their transplants come from living donors. Coming to our own institute, we have been pioneer in doing transplants in this state. When there was a question of the cost, so a lot of people think that transplants are being done only to fill the hospitals or the doctors' coffers, but that is not so, especially at our institute. So we have recently published this, where we had a public-private partnership. A lot of our patients had undergone transplant. To the tune of 70% of our patients were done actually under the public-private partnership under the various schemes. And even if you look at the result, it is not that because the patient is under the scheme, the results are inferior or we give them an inferior care. The results are in fact better or higher than even if you compare in those patients who had undergone transplants by cash paying. Again, coming back to the various states, Rajasthan in terms of donation, though in terms of pledging the organ, Rajasthan is the largest and the topmost state in pledging organs. But when it comes to donation, we don't even feature in the top 5 states of our country. So the top states are Telangana, Tamil Nadu, Karnataka, Gujarat and Maharashtra. So Rajasthan is nowhere near this. The deceased donor rate has significantly increased from the last decade, as already pointed out, but we are still nowhere close to the major countries where the rates are somewhere at 47 and 45 per million population. We are not even 1, we are 0.87 now. So what the intention was, we need to inform the august audience is that number of patients who are now waiting for an organ is significantly on rise, with new patients being added every day. Organ transplant today is a standard of care. You need to offer transplant to a patient who has got end stage either liver or other solid organ failure. There is significant scarcity of organs, and that is why we need to go towards finding living donors. And even in living donors, we have to push the boundaries because there is non-availability of cadaver donors, especially in our country. Brainstem death is legally death. That is what is very important. This, even if you take this one sentence out of the whole presentation, if this one sentence goes back with you in your mind, because a lot of doctors are also not convinced that brainstem death is death. There is heart beating, you can see the pulse rate, you can see the beep on the monitor, but that is, patient is not alive. Brainstem death is death. So that is why awareness of this and the organ donation was required. I would again request if you and your colleagues, and if you can communicate back to your society to start pledging our organs rather than take these organs back to heaven. Heaven knows we need them here. Thank you very much. We would like to acknowledge the Emeritus Chairperson, Dr. Vikas, the administration of MGUMST and the CCR review team for helping this. We'll be very happy to answer any questions regarding either the process of the organ donation, process of brain death certification, how do you manage, how do our intensivists, all of us are here to take on your queries.